Hello, I'm Deb Smith. I'm a licensed psychologist and board certified behavior analyst in the behavioral health department at Neponset Health Center, and I'm going to speak to you today about anxiety disorders. Before I begin, I want to credit the resources that I used for this presentation. One, the resources for the educational resources that came from the certificate program in primary care from the Center for Integrated Behavioral Integrated Primary Care at the University of Massachusetts Medical School. Dr. Hahn's presentation on anxiety disorders, downloaded from YouTube, and the Hunter Goody Ort and Dobmeyer book on integrated behavioral health in primary care. So today I'm going to speak a little bit about the rationale for addressing depression in primary care, defining anxiety and the different subtypes of anxiety disorders, a review of first-line treatments, and common management issues. So, one study showed that the two most common complaints in adult primary care are chest pain and back pain, accompanied by fatigue, dizziness, headache, shortness of breath, insomnia, numbness. So it's pretty obvious that a lot of symptoms that adults are presenting in primary care are also symptomatic of anxiety disorders. A report from the Surgeon General noted that anxiety affects approximately 26.9 million individuals. That's twice as likely in women. And 20% of patients in primary care meet the criteria for one of the anxiety disorders. It's one of the most common group of mental disorders. Patients are more likely to present to primary care versus a therapist for individual treatment. Patients are often seen in primary care multiple times before eventually being diagnosed. In fact, one study found that patients diagnosed with anxiety disorders had been seen an average of 6 times before receiving the diagnosis. And anxiety disorders are also associated with the occurrence of multiple medical problems, such as irritable bowel syndrome, asthma, cardiovascular disease, and chronic pain, giving evidence to the expression that anything that affects the mind affects the body, and anything that affects the body affects the mind. I think in terms of setting realistic treatment goals with your patients, it's important to look at the prognosis. So, immediate treatment response noted a 50% improvement. But in terms of full remission, those gains are more modest. So, in fact, a 8-year follow-up study of both pharmacological and non-pharmacological treatments revealed that only 40% of the population received full remission from general anxiety disorders, 31% for social phobia, 35% for panic disorder, and 12% for obsessive compulsive disorder. So this kind of gives evidence that anxiety is a disorder that we want to manage. It may not fully remit. So what is anxiety? Anxiety is a emotional state that is associated with an undefined threat. Something bad is going to happen. So, in some aspects, anxiety can be adaptive, right? I'm pretty anxious about my performance on a particular exam, so I'm going to study extra hard for it. But it's also, but it's the pervasiveness that can cause the impairment. So if I always have this feeling that there's this impending doom and something is bad, I have bad is going to happen at all times, you can see where my life functioning is going to be pretty impaired. Anxiety is comprised of both the physiologic and the psychological symptoms. So, anxiety is different from fear, which is an emotional state when the threat is specific and well known. So, for example, I am laying in bed and I hear a noise outside my window. I become pretty fearful because I'm worried about something, or I'm afraid of something specific, that is, somebody breaking into my house. Anxiety disorders are comprised of general anxiety disorder, panic disorder with or without agoraphobia, post traumatic stress disorder, obsessive compulsive disorder, social anxiety disorder, specific phobias, and anxiety disorder, NOS. And we're going to review all of those. So the first one, general anxiety disorder, is characterized by a persistent and excessive free-floating worry. So just worrying about everything. If it's in front of my face, that's what I'm going to worry about. And this takes place, and which needs to last for at least 6 months. General anxiety disorder that has the physiologic symptoms of muscle tension, insomnia, fatigue, as well as the psychological symptoms such as worry, irritability, always feeling like I'm on edge, poor concentration. The next one is panic disorder. So we have panic attacks, which are discrete, intense episodes of anxiety that peak in about 10 minutes and remit. So I explain to patients that these to kind of think of panic attacks as almost a wave. So they start small, they increase, but then again, they're going to go down. It's associated with a fear of losing control. I'm going to faint in public. I'm going to pass out. I'm having a heart attack. I'm going crazy. So some sort of catastrophic belief. And they can also occur in relationship with other anxiety disorders. So, for example, PTSD. So panic attacks are distinguished from panic disorder, which is characterized by a persistent concern about having attacks. So I'm worried that, for example, if I go into a grocery store, what if I have a panic attack? What if I pass out? And as a result, I'm going to send my husband to the grocery store all the time. So you can see where there's a change in behavior as a result, primarily as a result of the avoidance. Agoraphobia is a persistent fear of specific situations, driving, maybe going over bridges, closed or open spaces, any place where escape would be difficult or help would not be available. It can occur by itself, though usually it's associated with panic disorder. Social anxiety disorder is a pathological shyness. So this isn't just feeling a little uncomfortable when you're around crowds. It's feeling almost, the anxiety can be almost paralyzing, where you avoid any kind of interactions. Again, it has the physiologic symptoms of blushing, sweating, tremors, maybe some nausea, as well as the psychological component of fear, distress, avoidance, embarrassment, and these can lead to panic attacks. So the psychological, one of the symptoms may be if I say something, everybody will think I'm stupid. I'm not going to raise my hand because if I get the wrong answer, everybody will make fun of me. Again, there's some core belief that serves to exacerbate the anxiety symptoms. Post-traumatic stress disorder is characterized by exposure to traumatic event, a potentially life-threatening event, with a subjective response of fear, helplessness, horror, and the re-experiencing, and this can be in the form of flashbacks, nightmares, intrusive thoughts, avoidance and numbing, detachment, loss of interest, avoiding people and places, as well as arousal. So this hypervigilant, increased startle, poor concentration, anger, poor sleep. So I had a young man who had witnessed the Boston Marathon bombings. His mother was running in the bombings. And as a result of that, his symptoms included he was socially isolating in his room more and more. He was fearful to go out to the mall with his parents. He was didn't want to go into the cafeteria at school. So all of these symptoms were cues that he was suffering from post-traumatic stress. Obsessive compulsive disorder is different from obsessive compulsive personality disorder. So that's characterized by that perfectionism. Obsessive compulsive disorder can take the place of, it's characterized by obsessions, which is the reoccurrent intrusive thoughts or impulses or images. As well as compulsions. So, which are the repetitive behaviors or mental acts that somebody feels driven to perform. So, repeated hand washing, in terms of the mental acts, maybe counting each step that I take from the parking lot into the building, and if my steps are not even, I may have to go back and start all over again. That may be an example of a compulsion. Maybe obsessions might be worrying that the stove is left on, or I left the coffee pot on, and and even though I may go back and check all day long, I'm worrying. I'm continually worrying about whether that coffee pot is on or not. So this is different from just worrying about everyday problems. And then anxiety NOS. So this is kind of a catch-all. There may be symptoms of a anxiety, or there may be a phobic avoidance, but perhaps your patient doesn't meet every single criteria. The exact diagnosis is not known. For example, mixed anxiety and depression, social phobic symptoms related to a general medical condition, so a disfiguring dermatological disorder, and it's very, very common. So, assessment. When you're conducting your functional assessment for anxiety, you want to take a look at both what are the physiological factors as well as the psychological symptoms. What are the triggers for this anxiety? Is it triggered by loud noises? Is it triggered by going out in public spaces? How many What's the number of hours a day does your patient spend focusing on these symptoms, and give you an idea of how these symptoms are impairing and impacting your patient's life. Any activities that have been given up due to the anxiety symptoms. So, are there places that your patient is starting to avoid, hobbies they've given up, relationships that are impaired? Is this impacting on the job? So, an example maybe somebody with social anxiety disorder was passed over for a promotion based on how their avoidant behavior when they're around others. One of the benefits of being able to assess symptoms and is that it's going to help with not only your diagnosis but the response to treatment. So it's going to help with in terms of your self-management goals that you set with the patient also. It's important when you're assessing for anxiety to screen for comorbid conditions such as alcohol withdrawals, the amount of caffeine a patient may be taking, how many Red Bulls they might be drinking a day, any kind of medical conditions such as diabetes, hyperthyroidism, irritable bowel syndrome, major depression, bipolar disorder. So, a manic phase of a bipolar disorder may present like anxiety, and then some of the personality disorders. For initial management, I cannot stress the importance of empathy. As previously reported, these are patients that may have gone to the clinic 5 or 6 times with these symptoms, and people and may not have received appropriate treatment. People may be coming in with multiple stressors, such as work or financial stressors, domestic abuse, housing issues. Fortunately, we have client services here at Neponsit at Harbor Health. So, wherever possible, refer patients to for support around these issues, and then discuss and agree on realistic short and long-term goals. So the patient that wasn't able to go into the grocery store, a short-term goal might be some relaxation therapy, maybe some medication management that targets the physiological responses, where a long-term goal might be to decrease her symptoms over time so that she's returning to full functioning and able to go into grocery stores with a minimal amount of anxiety. And then again, to discuss treatment options. In terms of treatment, there is the pharmacological treatment. These are primarily serotonin selective reuptake inhibitors or serotonin neuroepinephrine reuptake inhibitors and benzodiazepines. The non-pharmacologic is psychotherapy, primarily cognitive behavioral therapy. The research has found equal support for both medication and psychotherapy, and furthermore, combining these two is not clearly superior. So you don't get an additive effect of adding psychotherapy onto medication, although in the acute phase there may be an additional benefit. And in the long run, psychotherapy may be better than pharmacological therapy alone, in part because the patient will have acquired some skills and maybe learned some new behaviors that are incompatible or with the symptoms of anxiety. Cognitive behavioral therapy has been shown to be efficacious for anxiety. And this typically consists of weekly sessions, 10 to 20 sessions. Cognitive behavior focuses in on the here and now. So that patient that isn't able to go to the grocery store, the focus is on, if that's the patient's targeted goal, is working on going to the grocery store. There's always homework that's done outside of session. So, for example, the patient in the wanting to go to the grocery store might first just practice some relaxation and just visualize going to the grocery store. And then when she's comfortable doing that, maybe go into the parking lot, to the door, to the grocery store. So that behavior is then shaped up step by step. The components of cognitive behavior therapy always include psychoeducation. There's cognitive components, so learning to identify and change the cognitive distortions. So, for example, if I have panic attacks, So being able to identify and know that I'm having a panic attack, that I'm not having a heart attack. This is going to be over in about 10 minutes. I'm going to be able to handle that. So that's a much more adaptive, those are much more adaptive cognitions than thinking, oh my God, I'm having a heart attack. I'm going to die. So there's the cognitive component as well as the behavioral component. I already gave an example of the graded exposures, going into the parking lot and then the grocery store and then shopping, and then also learning relaxation and anxiety reduction procedures. So deep breathing is a very important component of managing the physiological symptom for anxiety. It balances out, it increases the heart rate variability, which can help decrease heart rate and blood pressure and decrease muscle tension. So that's a very easy strategy to teach your client to take low and slow deep breaths, breathing in to the count of 4 and breathing out to the count of 6. Being able to practice that 5 to 20 minutes daily is going to have an effect on that client's sympathetic and parasympathetic responding. This is a resource for an excellent panic disorder handout that in integrated behavioral health we give to clients, that explains the cognitive and behavioral components to panic disorder, as well as providing some suggestions on how clients can cope and manage panic. So key points to remember is for anxiety disorders, when you're assessing anxiety, look for both the somatic and physiological component. Anxiety is a disorder that is chronically waxing and waning. Our goal is to be able to control symptoms, maybe as opposed to getting full remission. A recommendation is that all anxiety disorders initially be treated with an SSRI. If they are going to be managed medically, start slow with adequate duration, and that both CBT and SSRIs are equally effective.